Okay, Muhammad, you want to start? I think low activity is easy, so hopefully there will be easy questions. Let's see what's that, Muhammad.
I'll start 33. A 42-year-old woman with long-standing history of diabetes presents to her primary care physician with wound on the plantar aspect of her first metatarsal head, which has been present for several weeks. She cannot recall any antecedents trauma. Urgent referral for further evaluation should be promoted in the presence of A.
So let's before we go there, let's see what does she think she has. So so she cannot strong urgent referral for
Yes.
she's diabetes.
Yeah, she has
an ulcers.
Yeah.
Urgent referral. When we do urgent referral, is a kind of infection,
anticipation, right? Of the infection or gangrenous.
يعني بس هلا هي ulcer هون ما في gangrene. معناتها unless if she has a bad infection, it's urgent. عرفت كيف? This is the only reason, and this is what I understand from the question. إنه the urgent referral معناتها they ask us إنه ما في gangrene toes or something, that's ulcer. Because the only thing, because ulcer you don't have to do an urgent. You can say it's a vascular after a week, 10 days, whatever. But urgent if you have an infection. So let's see what they're saying. What option they give us?
A serous drainage from the wound.
Okay, I mean serous doesn't mean that infection, right? Like
infection. Yes.
Because serous could be like a Charcot joint, I have serous drainage. So wound always they have a drainage. So I don't think it's you see the key is the urgent, it's the key in the question,
Yes.
So I don't think this would be a good options. Okay.
B, history of prior wound on the contralateral foot. Has no.
Doesn't mean much really. Yeah. Because when she has lateral foot ulcer, that is she's a vascular disease, which of course we know that. So it doesn't make difference really. Okay.
C, lack of palpable pulses in the affected foot.
Yeah, you can put it, but we know she has a vascular, issue. So doesn't have to be like bubble. Like if we saw the patient with the ulcer in our clinic, she has no palpable pulses. If she has no infection, we would have to like a week or 10 days, right? We don't admit her right away. So the only time we admit patient from the clinic to the, if you have an infection. So we'll go back again. We're looking for infections.
Okay. D, unexplained hyperglycemia.
Okay.
This can be
and mass infection. There's no questions. Next, last one. Duration. You're there? Hello? I can't hear you.
Yes, doctor. Duration of the wound.
Duration of the wound. Duration doesn't make a difference, really.
Yeah.
Don't explain hyperglycemia. We know that when you have a bad infections,
it can be.
The reason why hyperglycemia, the reason why it's very hard to control sugar when patient has bad infection,
Yeah.
You see, people, they don't always show you like a straightforward sign of infections, like muscle drainage, fever, cellulitis. Sometimes we don't see this sign, because some people are immune compromised, they have a different issue. The reason why they come us too late, because most of the time they have an infection, they don't know about it because they don't have an obvious sign of infections, So not every time, especially with diabetic people, we see an obvious sign of infection, but unexplained hyperglycemia, like patient taking as same dose for like a year and he's fine, and suddenly now with the same dose, his sugar is not coming down. I think this is can explain that mean has a bad infections, So I think this is what the whole idea from these questions, You agree with that?
Yes, doctor. I think the urgency in this case is the infection.
Yeah, because an infection, not any other one is a sign of infection. It's not very good questions, but I don't know, sometimes questions are tricky, but this is what they want to say, All right, let's not waste too much time, but the whole idea is that if you had an infection, you need an urgent referral. This is the only time. And again, in our clinic, The only time if patient comes with an ulcer, the only time I admit him right away to the as inpatient if you see an infection, right? So that's it. So whatever they give you the answers, look for infection. This is the whole idea. Okay.
Yes.
All right. Well, let's go to the next one. So Sam, you want to take next one?
Yes. Yes.
Okay.
Mhm. Okay, a 63 years old obese woman presents with a smelling ulcer on the dorsum of her left great toe, with tracking erythema and general feelings of malaise. She is neuropathic from the ankle to the toes. Recent lab work shows her hemoglobin A1C is 11.2. She has a fever of 102 Fahrenheit degrees of Fahrenheit and heart rate of 110 beats per minute. The next step is in management is, so she's an old lady with active infection with sepsis almost. So she's febrile and tachycardic, leukocytosis with foul smell in the left great toe with cellulitis.
So what do we do?
Usually we have to admit and start IV antibiotics and to take her for debridement plus minus amputation of the big toe.
That's true. That's it. You see?
Yeah.
Always imagine when you get a question, like you're in a clinical, scenario, like you're in the clinic and get this patient, what are you going to do? So don't try to find what the best answer. Before you answer, just think, what should I do? And then go through the question, So I agree. She has an infection, very active infection, fever, tachycardic. We have to admit her, antibiotic, and take the toe out. So let's see what options they give us.
Okay. A food culture, oral antibiotics, and close clinical follow-up as an outpatient. No. She's septic. We cannot do it like this. Admission, intravenous antibiotics, and 3 view x-rays of the right foot and foot cultures. It's not enough.
It's not enough, but unless they didn't give you any other reasonable answers, I mean, it's not right to get a view x-ray to rot osteomyelitis, but it's not enough. So let's see what the other options, if you have better options,
Immediate operative debridement with possible open amputation of the great toe or ray with cultures. This is accepted.
That is more reasonable.
Angiography with possible revascularization. No, we have to deal with the infection first.
It's going to do it. They said what the next step. It doesn't mean the only step. See, Sam? They still have to do an angiogram or vascularization, but they're asking what the next, but not the only step. So yes, you still have to do angiogram, but later on, after, not the next step. First step, get the infection, give antibiotic, admit her, do toe amputation, and then we'll do angiogram and possibly vascularization. Correct. Okay.
Yeah. Right below amputation. No, it's too much.
If she is, how old is she? She's 63. Unless she's like bedridden and she's unstable, then yes, could be, but not in this scenario. But if patient like unstable, very septic, bedridden, 80 years old, then yes, this could be also a good option,
Okay.
But in this scenario, just take at the ward, debride her, admit her, antibiotic. You do an X-ray for, to rule out osteo, but you're going to take a toe anyway. So I don't think the X-ray will help much, really. The only X-ray will help if you not question, should I do debridement or not? Should I do, bone infection? Should I give an IV antibiotic? But if you plan to take her to the OR and take the bone out, I don't think the X-ray will help, because you're going to take it out anyway. All right?
Yes.
All right. Let's go to Ahmed. Ahmed, do you want to take next question?
Okay. Yes, please.
The next question is here. Oh, it's too fast.
Okay. 53-year-old obese woman is admitted with fever and right foot pain. She noticed malodorous wound on her right foot over the last 2 days. On examination, she has palpable femoral, popliteal, and pedal pulses. She has minimal sensation to light touch and monofilament bilaterally. And the right foot is swollen and red with a small draining ulceration under the first metatarsophalangeal joint. The most appropriate initial radiographic study is X-ray.
Okay, so why you want to get an X-ray?
This is osteomyelitis. Looks like it.
Osteomyelitis. So it's very easy already. I mean, something, some of the question really just straightforward. Let's see what options they gave you. Plain
Plain
radiograph.
radiograph,
Yeah.
arterial
What else? I mean,
Doppler,
why you need an X-ray? Only for looking for osteomyelitis or for something else?
and gases.
Gases. What else?
Probably fractured bones.
Correct. This is all sign of osteomyelitis, right?
Yeah.
You can see fractures. What else? What about the periosteum?
Foreign bodies, periosteal spur,
Okay.
and
The foreign body is very important.
foreign
because
body, yeah.
These people, they have a neuropathy. You see, they told you that he has a neuropathy. So sometimes, you know, they have like a needle inside, they don't feel it because they step on the nail or needle, and the needle is the foreign body there. And if you treat it with antibiotic, they never heal until it comes out. So really, almost every patient with a, you know, diabetic with a neuropathy and has an ulcer, you need to, you know, do an X-ray to look for foreign bodies, you know.
Yeah.
I'll tell you, one time I have a patient with diabetic foot, and he has an ulcer in the plantar aspect, and we treat him for a long time. He's never healed. And even X-ray showed no foreign body, nothing, no osteo, but it's never healed. And then, I don't know, for some reason, I said, let me put my hand inside his shoes. And it's a blade inside his shoes, you know. I think he stepped on the blade, and the blade like half embedded in the shoes, and keep cutting this ulcer every time he, you know, and he has neuropathy, he doesn't feel it, you know. So you'd be surprised, you know, and these people who has no neuropathy, what could happen to them. So you have to look for that. So it's the reason why also we get an X-ray.
Sure.
Throughout, you know, and also looking for the gas and periosteum elevation, all the things, sign of osteomyelitis. So what about the other option? Let me see. Arterial duplex testing. Let's go through them.
Later on. And the patient has pulses, actually.
Okay, so you don't need that. That's correct.
Same for angiogram, arteriogram.
What about MRI?
MRI will tell us that that's something that is not seen on an X-ray.
But which one is better as, you know, I mean, which one is better for osteo? Is a plain X-ray or MRI?
MRI, of course.
Okay, so why didn't pick up MRI?
Because this is the first investigation, the first choice.
Not the initial, right. You don't want to jump to the MRI. So if he's tell you what the best, of course, radioactive study will be MRI. But if you want the most appropriate initial study, do an X-ray first. Because if the X-ray didn't show any sign of osteo, then you don't need MRI. But if it was questionable osteo, then you do an MRI.
Yep.
All right, let's go back. Okay. Let's see if anybody here, anybody fellow here. Okay, let's go, Muhammad.
Yes, doctor.
That's good. We're going fast. Let's go. 36. Easy question today. And it's just straightforward. All right, let's see what that.
Okay, a 35-year-old man was brought in by ambulance to the emergency room following an isolated high-velocity gunshot wound to the right leg. He was hemodynamically stable but without distal pulses. CT angiogram demonstrated occlusion of the superficial femoral artery with associated hematoma. On surgical exploration, the mid-SFA is found to be completely transected with 10 centimeter defect after the proximal and distal artery edges were debrided. A concomitant small injury to the femoral vein was seen and controlled with simple suture repair. The best means of repairing the arterial injury is the best means of repairing the arterial injury. Yeah,
so he has we have a 10 centimeter defect. Yeah. We have a trauma.
Yes, sure.
Patient stable.
Yeah. So you can do the definitive treatment now.
Okay.
So since you're already surgically exploring this patient,
Right.
and you have in the same foot you have femoral vein, so I
Right.
prefer to use the contralateral saphenous vein for repair.
Why is that? Why you want to do contralateral?
First, because he has femoral vein injury in the same foot.
Okay.
Plus, it's a trauma.
What's the problem? Why you want to go to other one if you have femoral vein injury in same leg?
Usually, we in trauma per se, we usually use the contralateral
No, I
vein.
know
If
that,
you,
but I'm saying why.
yeah.
So people they know because this is
Yeah.
educational.
Yeah, because usually they get edema and you need the superficial system to be opened also.
Okay, this is good because they injure the femoral vein, right? And they suture it.
Yes.
There's always a chance the femoral vein could thrombose, right?
Yes. Yes.
The
Yes.
thrombose, the collaterals is a superficial vein.
Yeah.
So better to keep it. This is one
Yeah.
reason. But the other reason, because when you have a trauma, most of the times, like a saphenous vein is already traumatized, you know,
Yeah.
because of the injury. So the reason why, you know, maybe it's not, you know, not thrombosed, but traumatized. The reason why it's always better to go to other legs, you know.
Yeah.
What if both legs are traumatized?
Both
They have a
like
trauma for
the
both.
saphenous vein were traumatized.
Yeah,
Use the
just they have like same that they have the defect, but the both legs now. So which vein you going to use, the right or left?
no, the same foot.
The same. You pick up the one. You pick up the best vein really. You cannot tell how which one less trauma, you know. So when you have these things, both, just pick up, see which one is the leg less trauma, which one's away from the saphenous vein. So you have a choice to pick up with the best conduit. But the whole idea, you need to pick up a best conduit. This is the whole idea, you know. Otherwise, they thrombose, you know. What if patient is hemodynamically unstable? Because now he's stable. What if the same scenario, but patient is unstable? So what do you do?
You can place shunt and you stabilize the patient and you bring him later for definitive treatment.
Yeah. So if he's unstable, you would a shunt. Yeah. Have you done that at Shimesi? I mean, have cases like that, you put a shunt or all the repair?
No, never shunt. Usually they are a bit stable patient. I think all the penetrating trauma should usually they are isolated, so they are a bit more.
You didn't have any case like that where the patient was unstable and you have to put a shunt.
No.
Yeah, I mean, me the same. And very rarely to put the shunt. You know, most of the time the patient is stabilized, or stable. Yeah. Unless you work in a major trauma, you have a lot of traumas, then you may get to this point. But the whole idea, if patient not stable, then you have to put a shunt. This is a teaching point, okay?
Yeah,
it's not the time for different treatment. Put a shunt, and then later on, when he becomes stable, bring him back, and then you can fix him. If it's stable, you have a time, better to fix it. And here we don't use any prosthetic, okay? Because unless he has no vein, and you can maybe use and you have to go fast, you can use prophylactic, then yes, I can use a temporary, but then later on, most of it, I'll bring him back and put a vein, especially young people. But let's say he has no vein and you have to fix the artery and, then yes, you can use prosthetic, but I think this would be just temporary as a bridge until he gets better, and then you bring him back, and then you can take a vein from the arm or something like that. But don't waste your time, get the vein in the arm where patient is like major trauma and you just want to get him off the table, All right? All right.
Yes.
Let's see what options they give us here.
So A, placement of intravascular shunt and return to the operating room in 24 hours for definitive repair. I think this when the patient are unstable.
Correct.
Primary repair in end-to-end fashion. I think the indication, it has to be less than 2 centimeters for this, and it carries a lot of risk of stenosis and tension. Yeah.
No, you can't. 10 centimeters too long. Yeah.
Yeah. 10 is too. Interposition graft with BTFE
Right.
high risk of infection. Interposition graft with ipsilateral great saphenous vein. We
Okay.
talked about this, and the interposition graft with contralateral great saphenous vein. I think I will choose this.
Choose this one. Okay.
Yeah.
Again, just straightforward case really. I'm saying lower extremity is, but you know, less controversy than aortic. See, aortic carotids are more controversial issue. But this is what our bread and butter, you know, cases every day. Well, let's get 37. Sam?
Yes, sir. A 75 years old diabetic man presents with a 2 centimeter right malperforance ulcer over the right first metatarsal head, which probes to bone. Okay. Despite offloading and local wound care, the ulcer has not healed after 6 weeks. ABI are non-compressible, but the toe breaker index TBI on the affected side is 0.1. Angiogram demonstrates occlusion of the below-knee popliteal, posterior tibial, and anterior tibial arteries, with reconstitution of both the dorsalis pedis and posterior tibial artery, posterior tibial arteries in the foot. The best approach, if angiosome directed therapy is desired, would be.
Okay.
So we are talking about an old man, diabetic, with a chronic non-healing ulcer in the foot with it's a critical level of ischemia, not failed to heal with conservative management. So
Correct.
we will think about revascularization.
Correct.
In terms
But the only thing they want to do the angiosome. These are the question. And they know you're going to do revascularizations, but the angiosome and the area, where is it? Also over the right first metatarsal head.
Yeah. Yeah.
So which one is the anterior tibial or posterior tibial?
Yeah, we will think about anterior tibial.
Correct. So the anterior tibial dorsalis pedis really. So this is the artery for the angiosome, you know, for this area. So they want you to get the blood to that area. Okay. I think this is what the question. So let's see which one will give us, because a lot of options you can do really, but let's see which one fit with this scenario. Okay. But the whole idea, you want to get the blood to the anterior tibial artery. And he has occlusion from popliteal artery below the knee popliteal artery. So you have to presume anything above is open because they didn't mention. So if they did not mention it, that means it's open. Correct? Because they said occlusion only popliteal below the knee, anterior posterior tibial. So that means camofemoral is open, SFA is open, popliteal above the knee is open, everything, iliac is open, aorta is open, nothing, you know, because otherwise they will mention it. So let's see what options they give us.
Yeah. Femoral endarterectomy and profundoplasty is not a valid option because we consider it as open.
Right.
I mean, femoral posterior tibial bypass. Yeah, we said we are talking about the angiosome, so we want to save the anterior tibial.
Correct. So this could be an option, but if it's no anterior tibials, then this would be my second options, you know.
Yeah.
But also femoral. Keep going.
Yeah. Angioplasty and stenting of the popliteal artery with angioplasty of the peroneal. Actually, we don't prefer to put a stent in the popliteal artery.
You see, this is, in the people, they do that. They do stent popliteal artery. So you cannot argue on this point. The argument will be peroneal artery.
Peroneal, yeah, it's not.
Because they said angiosome. If they said to anterior tibial, angioplasty stenting of the popliteal artery with angioplasty of the anterior tibial, yes, people, they do that. Then I cannot say wrong. You see? Because maybe it's not the best treatment. Because now, you know, below the knee, we know now, we know endovascular is the first line of treatment for below knee arteries now, even with the recommendations. The problem is the patency is not as good as the bypass, but the limb salvage is almost the same. So you have to look for limb salvage. We know that endovascular does not give us a long patency like a bypass, but as a limb salvage is not really a major difference, you know. Reason why we always try with intervention if we can, you know.
Yeah.
But again, because they said angiosome and they put a peroneal artery, this will exclude these options, okay?
Okay.
All right, let's go next one.
Above knee popliteal dorsalis pedis bypass. Yeah.
Leave it to the end if you are not sure. See what the last options.
Okay. Retrograde access of the posterior tibial artery with angioplasty and stenting of the superficial. This is not correct because posterior tibial is not the angiosome, the proper angiosome.
Yeah.
And angioplasty and stenting of SFA, we consider it patent. That's why.
Right.
So I will choose yes, D.
Yeah, I think D. Above the knee popliteal to dorsal artery, you know. I mean, structure of the question is not very good because they have to tell you really frankly that SFA is open, popliteal is open. They cannot just leave it like that, you know. So the structure of the question is not very good. But if you think about angiosome and dorsal, so anything has dorsal artery should be the correct answer. This is simple like that. But I don't think it's a good structural questions, you know. But again, I mean, this patient, if somebody wanted endovascular, I think you can try it. Why not? I mean, it's not difficult, especially in the only popliteal below the knee and anterior tibial. You can cross them, balloon them, and you can get good results. So this is one. There's not none of these options here, but they put them. This could be also another options. Well, let's see. We have. I think I saw Ali. Hi, Ali. How are you? What do you think? Will you do bypass right away, or you do an intervention usually with this kind of patient?
Really, I agree with you with endovascular treatment of these patients. I use in these cases the two wires. I try to put a wire in the anterior tibial and a wire in the trunk, popliteal trunk. So, and I do angioplasty for this case. I have a case I will share it with you on this group. I think.
Oh, this is good.
Double wire angioplasty. I think it's the best way for these patients. To put stent or not to put, it depends. If you do, it's better not to put. But if there is any dissection, then you have to put a stent, a self-expandable stent. Sure.
Do you do a drug-coated balloon or regular balloon?
No, regular balloon. Regular balloon.
Correct. Yeah. Yeah, I agree with 100%. I think the double wire is a good idea because this way, because what happens sometimes if you open one artery, you can close the other one. So you put two double wires, then you protect both of them, you know. I think is a good idea, you know. Use 014 wire, right?
014, sure.
Yeah, I think it's a good idea. And even you can get the flow to both. Yeah, the anterior tibial and posterior tibial artery. So I agree with you. This kind of patient, at least I'll try endovascular first. If it doesn't work, then I'll go with a bypass. But in the exam, like for this question, this is the only options you have. So you have to go with this one, you know, above knee popliteal to dorsalis artery. Yeah. For drug-coated balloon, I mean, I don't like to use it much below the knee. Even though the patency is a bit better, I was concerned if you have an ulcers, this, you know, the cytotoxic, you know, material in the balloons, I'm always concerned that may flush down and you know, prevent or delay the wound healings, you know, because the first, you see, remember from Medtronic, the first one they use Medtronic, the below knee, below angioplasty, they have to put it out from the market because they found even the patency is better than normal balloon, but the amputation rate was higher. So you have to be careful below the knee. Yeah. All right, this is good. But Sam, who is Ahmed? We come back to you. Let's see what the above knee bypass was the right answer. Okay. Let's go to 38. Like trauma today.
Okay. A 23-year-old man presents with level 1 trauma after being stabbed in the left thigh. On admission, he is tachycardic and hypotensive, but is awake and alert. He complains of pain and numbness in the left leg. He has a large pulsatile hematoma in the left thigh and absent popliteal and pedal Doppler pulses. He was emergently taken to the operation room with the left leg was explored and transection of the common femoral artery identified and repaired. The vein was intact, although the femoral nerve appeared to be damaged. The expected neurologic deficit would be...
Wow.
Okay.
So the whole question, they just want to tell you that what the nerve, femoral nerve,
Yeah.
it's being cut. So what you expect? You have to be good in anatomy. Did you read anatomy recently?
Not really femoral nerve.
Yeah, it's a tough question. Let's see somebody has a fresh anatomy. But I tell you in general, let's talk in general. Before we go like in details. Femoral nerve, what muscle it supplies? Let's talk about motor. Forget about sense.
In the thigh.
In the thigh. So this is the thigh muscles, all supplied by femoral nerve. What about sciatic nerve? What is supplied?
It would supply the medial
Yeah,
and
the leg and foot, because give you the tibial and peroneal nerve, right?
Yep.
So sciatic nerve injury will give you weakness from the muscle of the leg and foot, where the femoral is supplies the muscle of the thigh. Sensation is different, of course, different area of sensation, but the most important to know what the motor, So the sciatic nerve give you two nerve, give you the tibial nerve and peroneal nerve, right?
Yes.
Tibial
Yes.
nerve supply which muscles?
Anterior group muscles, the
tibial nerve.
dorsiflexors of
Tibial.
foot.
The dorsiflexion, right? So it's a posterior muscle, not the anterior, the posterior.
Yeah.
Right, whereas the peroneal supplies the anterior and lateral compartment, which is responsible for dorsiflexion.
The plantar flexion. Yeah.
No, dorsiflexion. See, the foot is opposite than the hand.
Yeah, so sorry.
So the dorsiflexion, right? Because dorsiflexion up.
Yep.
And there's and plantar dorsiflexion. The reason why you see if you peroneal cut, we see a foot drop, correct? The reason why.
Yes.
So let's put this in your mind. This is very in general. You think what about the nerve without being specific which muscle in each one. So let's see what options they give us here. So you cut the femoral nerve. What are you going to see? Let's see first one.
Okay. Decreased sensation of the medial thigh and calf. Unlike,
See,
sciatic.
I'm expecting that you don't know anatomy, right?
Mm.
So sensation, it's hard to see. Motor is easy because the muscles. Sensation is different. Sometimes femoral nerve go all the way down. So I'm not sure. So we put this on the side. Okay. Let's see the other options.
Decreased sensation of the medial thigh and weakness with knee flexion.
Okay. So now they talk about knee flexion, right? So talk about thigh muscle. So this also could be correct, right?
Could be, yeah.
Let's go to the next one.
Decreased sensation to the entire lower leg with weakness with the knee and ankle flexion.
Knee and ankle flexion. Okay, now flexion, ankle has nothing to do with the femoral nerve, correct?
Yeah.
Said the ankle is supplied by the sciatic nerve.
Sciatic, yes. Below
so it's too far. So this is okay. So C is for sure wrong. So okay. So we have A, B. Now let's go to D.
D, decreased sensation to the anterior thigh and weakness of the hip flexion and knee.
Hello? I can hear you. Still there? Ahmed, I cannot hear you.
Okay. Again, D. Where are we? D. I had a disconnection. D is possible.
Okay, what next one?
E, weakness with the flexion and extension of the knee.
You see, it is a tough question. You have to know your anatomies,
Yeah, very well.
So you have to go and read, guys, your anatomies, So let's see what they give us. So the answers, because something around the knee. the hip flexion and knee extension. So this is what usually is, you know, hip flexion is just for psoas muscles, muscle is supplied by that. So anyway, so good guys, you need to go and read about the nerve of the legs. It's very important. Can get a question like that. It may give you different type of questions, you know. So it's very important to know the femoral nerve, sciatic nerve, and tibial nerve and peroneal nerve. Okay.
Okay.
Let's see. Injury to the femoral cause of decreased sessions over femoral sciatic peroneal nerve, tibials after station. Okay. All right, guys, I think this is just have to read it. All right, let's go to the next question. 39, Muhammad.
Yes. A 53.
By the way, do you know the nerves?
يعني معقول يعني هذا.
Did you guess it? I mean, I didn't guess it. Did you guess it?
Yeah, I guessed it right. This
Oh,
one.
that's good.
Yeah. بس كل النيرف على الشورت تيرم ميموري يعني كانت remember it.
For the exam, you have to read them.
Yeah. A 53-year-old man was injured in helmet motorcycle accident where he sustained a direct impact to his abdomen.
Okay.
He has numerous rib fracture and penetrating chest wound, but no peritoneal signs.
Okay.
Upon evaluation, he is found to have cool, painful, and pulseless bilateral lower extremities.
Okay.
The CT is shown in the figure. The best management for this patient is.
Okay, let's see what the figures. Here's the figures. So what do you see?
Yeah, he has distal aortic and bilateral common iliac occlusion.
Yeah.
Secondary,
Secondary to trauma. It could be
secondary to trauma,
thrombosis,
maybe dissection and
could be thrombosis, you know, but it's localized. Must be dissection because just localized, you know.
Yeah, traumatic dissection.
Yeah, I think from a trauma.
And the patient he has acute ischemia in the foot,
both
in the bilateral foot. So the best management.
So what do you do? Let's see what option. What do you think if you get this like patient? And she may see.
Yeah, this one.
Well, let's take the surgery or endovascular.
Yeah, and for me, this is endovascular because there is no indication to do laparotomy for this. So
indication is not the time to do biofilm, but then maybe has a bowel injury, so you don't want to put a graft, you know.
Yeah.
So I think now endovascular become really the first option in trauma. Except, I mean, it's different. Like superficial femoral artery, different. If you have femoral, superficial femoral artery, profunda legs artery is different because an open wound.
Yeah.
But and it's easy because most of the time you explore because there's a hematoma there, you know. Mm-hmm. But intra-abdominal aortic injury, like aortic trisection, we see it in trauma. Aortic dissection, like here. All the studies show that endovascular you have a better outcome, you know, especially patient with trauma, you know. So I agree, I will go with endovascular. What do you do in endovascular?
This is bilateral kissing stent most of the time.
You're right. So just go.
But what about hibernization during this case, doctor? Fully hibernized or?
It's not. I mean, you can do it. I mean, it's better to give him.
Yeah.
If you see this, we go back to the same controversial issue: should we give heparin or not? You can give a small dose, or if he cannot, if he has like a bleeding from somewhere, can you wait? It depends how is the foot. If the foot is cool and pulseless and really ischemic, no, I would not. I mean, it's okay. I just go and give small dose of heparin, or even you can do this without heparin because it's very quick. You know, just go 2 stents and put them, and you're done with that. You know.
Yeah.
But always, you know, when you do something, do the best for patient. Don't worry about the other things. You know. So unless if you have intracranial bleeding, it's a different story. But if there's no intracranial bleeding, I will give heparin. I may give like small dose heparin, and then always I give protamine. I can deal with other issue. because legs ischemia is very bad. If you don't treat it right, you end with a major issue. You'll get thrombose, and get an ischemia, then amputation at 53 years old. So I will not do that, you know. I will do is the best. Like, give you an example. Patient come with abdominal pain, and you think he has an bowel ischemia with SMA occlusions, and his GFR like, you know, 30. Okay, and you want to rule out bowel ischemia. What do? Do you do CT angiogram or do ultrasound, or what do you do?
No, I will do the best.
For the patient, yes. What about the kidney? Otherwise, we can fix the kidney. It's about ischemia. If you don't fix it, he will die. He will die. You know.
Yeah,
So go and
especially
get CT angiogram, even if it's a GFR 30. Don't care. Don't worry about it. The most priority now is to rescue his bowel, because if you don't do that and he ends with a bowel ischemia, he's a dead person. You know. So you see, always you have to, you know, weight risk and benefit. And the same here. The most important now to fix his iliacs. You know. Because he has bladder-leg ischemia, you know, cold. So don't worry about giving some heparin. If he bled, okay, we can deal with that, you know. So, so this is the way you have to think about it, you know. All right, let's see what options they give us.
Yes, doctor. Bilateral covered stent placement. I think,
it's not wrong, but I don't know why it's covered.
Because
we'll ask Ali. Let's go with another question.
There is sign of acute thrombus I wanted to ask you about. It looks like there is a thrombus over here, so they are afraid from rushing the foot.
It's not wrong, you know.
No,
it's not wrong.
B, aortobifemoral bypass. C, axillary bifemoral bypass. D, operative thrombectomy. D, catheter-directed thrombolysis.
Okay, well, let's go first. Aortobifem, of course, too much, and axillobifem is too much. This way, very obvious. Why don't do open thrombectomy?
Because you will not treat the dissection he has.
Correct.
So you're just
right. Because somebody said, why should put a stent? Let's do thrombectomy so we can avoid stent pending in young people. But this one, no, because we know the pathology it's a dissection or transection, so it's better to do right away stenting. You know. What about catheter thrombolysis?
The same, I think, and
risk of bleeding. He has a major trauma, has rib fractures, you know.
Yeah, the risk of bleeding.
I think the reason why they put a cover stent, they're afraid that maybe it's a perforation here, you see. Maybe it's a transection, you see. I think this is the reason why they choose a cover stent, you see, because this is kind of like transection, you know, because of trauma. Dissection, transection, you know. So maybe to be on the safe side, just put the cover stent. So it's not a bad option, you know. So I think I will go with A. But if they put uncover stent, then become problems. They didn't put it here because it's controversial. But I think what they want to say that if you have a like aortic transection, you know, we put a cover stent, you know. So the same here, like, you know, there's a transection, so it's better to use a cover stent. I think this is the idea behind using cover stent. Let's hear from Ali. Ali, what do you think, Ali?
I agree with you. If you have the cover stent, then you can use it. But if you don't have it, you have to go to aortobifem or aortobiiliac bypass.
Okay. If you don't have access to that, of course. If you don't have access to stent. Yes, I agree with that. Yes. Aortobifem or axillobifem, depending how bad the patient. If the abdomen is hostile, you have a bowel injury, better to do an axillobifem. If the patient is old, but if the patient young and he has no bowel injury, abdomen is clean, then you can do aortobifem. Yes, if you don't have endovascular, but don't delay the patient. You know, this is what usually the bad thing you see. Like if you don't have a stent.
For the axillobifem, he has a thoracic trauma, I think, in the question, no?
Let me see. Had a rib fracture. Maybe you're right. Let me see.
Yeah. Then I will evitate to go to even on the other side, the same one.
Well, I'm saying that this shouldn't have to be made during surgery. So what the best options? But this all options there. I mean, all these options really are viable, except for thrombolysis and open thrombectomy.
Contraindication in trauma, in acute trauma, it's contraindication.
Yeah, that's correct. Especially you don't know what situation with intracranial bleeding or not, you know. All right, this is good. All right. Well, let's go to me, Bassam. We'll get back to you. 40. Go ahead, Bassam.
A 32-year-old man and recreational triathlete has pain with exertion in both calves and feet, which has worsened over the past several months.
Okay.
Athlete, okay. A wound has been present on the dorsal aspect of his right second toe for 3 weeks. His primary physician had obtained a magnetic resonance angiogram.
Mm-hmm.
The diagnostic imaging approach that would best help with planning for surgical treatment of the left leg would be.
Okay.
Right.
Before we go there, what options? You know, what do you think he has? Is an athletics, as a recreational athletics. Anytime you see athletics, what trigger in your brain? What do you think? The first thing. Patient athletics and young guy.
Yeah, like either chronic compartment or the
Entrapment syndrome, right?
yeah, entrapment syndrome. Yes.
Yeah, it's called popliteal entrapment syndrome. This is typical. When the most you see athletics, young guy, the first thing they want, I mean, just by default, 90% they want to tell you this is an popliteal entrapment syndrome. The second thing, you look at the X-ray. Let's see the X-ray. The same. You see, it's popliteal lesion here. See, it's complete occluded popliteal artery. Okay.
Yeah.
And he has, of course, distal embolization. You can see posterior tibial is occluded. Sorry, here. And anterior tibial is occluded, or peroneal. This one, I think, this peroneal is occluded. So he has embolization. So he has an occlusion here, and distal embolization. The reason why he ends with the ulcer, because usually entrapment syndromes they come with claudications. They don't come with an ulceration. But this guy's, I think, has been there for a long time. He's 32, and see, he said worsening over several months. So must be the artery thrombosed. And he emboli now distal. The reason why he has now toe gangrene and all the things, you know. So they're talking about entrapment syndrome. So what they said, what the best imaging. Now, when they're not talking about what going to do surgery or whatever, you're going to do a surgery. So what the image will help you to do to plan your surgery. When you have entrapment syndrome, what's the problem is gastrocnemius muscles, the medial head. We have different type. We have like 4 type or even 5. Somebody said 6. But whatever, the major is your 4 type of entrapment syndrome. So the main problem with entrapment syndrome is anatomical problems because of the muscle, right? So when we fix entrapment syndrome, always plus, of course, fixing the artery, we have to cut the muscles. So we have to know which one is the type of the entrapment syndrome, is type 1, 2, or 3, or 4. So what images will help us? This is a whole question. What help us to plan your surgery, to see which muscle I'm going to cut, you know? So what do you think the best images will be for that?
MRI. Sorry, MRI.
Yeah. MRI, it's no question, okay? So now we understand the question. Now we go to the answers. But this is what they hold questions, you know? They not tell you what you're going to do, what type of surgery. They want to know what the best imaging will help you to plan your surgery, because the surgery will be cutting the muscle, plus, of course, fixing the artery. So the best thing is to go with the MRI. So let's see what option. He already have an MRI, so I don't know why they give us this question. Let's see what they give us here.
Okay. Duplex of left popliteal artery in neutral position.
It's useless.
No, it will not help, yes. Duplex of left popliteal artery in flexion and extension. This can help to diagnose.
Right.
Probably.
You have a diagnosis, but it's not planning your surgery. And the second thing is that popliteal artery is already thrombosed now. It's not like already compressed. So now I don't think you're going to see this change even. You see it when you have only compression, not thrombosis. So so I don't think this would be good options. Okay.
Axial cross-sectional imaging from MRA.
Okay.
Okay. Yeah.
Let's go next one.
Angiography of left popliteal artery in neutral position. Also to diagnose, not to plan.
To plan surgery. Okay.
Yeah. Angiography of left popliteal artery in flexion and extension. The same.
Right.
So back to MRI.
So really what you
yeah,
want to do, because here they have MRIs, MRI is MRI. So you just want to do an axial
Yeah.
because you want to see the muscle. You see, this one, you cannot see what's the problem. You cannot tell which type is this one. You see with this one.
Yeah.
Because you don't see the muscle. It's reconstruction, you know, it's corona. So you want to get the axial images so you can see which muscle compresses the artery. So I know which one to cut, you know. So I think this is what I'll do, you know. Ali, have experience with the entrapment syndrome? Do you need to add something? What about treatment to this one? What are you going to do?
Are you asking me?
No, I ask about first part, not the second part. The first part. What about entrapment syndrome? Do you see a lot? I mean,
Yes, we see in young people, even in youth age, in the teens age. So we see it, and we treat it, or by making a bypass and transection of the muscle. So we treat it. Yeah, we see and we treat them.
Do you go posterior approach to cut the muscles, and you go into positioning graft?
Posterior approach.
Yeah, I think it's the best options, you know. I mean, I never saw something like that. It's very extensive. Most of the time I see is compression and claudication, but this guy is really bad. See, he has embolization and thrombosis. But yes, I agree with that, you know. You need to cut the muscles and then it depends. I mean, I'll open the artery and see how the artery, if just clot, I can take it out because the main problem is a compression. If the artery is fibrotic, so what happened is the reason why even asymptomatic compartment syndrome need to be, I don't know, I think it need to be fixed because if you leave it alone, a patient has
it will give problem. Yeah, you have to fix it.
Yeah, I think so. Because if you don't fix it, then the artery becomes fibrotic with the time, and then they have to replace it. Then it becomes really more difficult, you know. So I think if you diagnose, it has to be fixed. Yeah. All right. So this is a good question. Well, let's go to next one. Axial cross section. So it's correct. Ahmed, we are back to you.
Okay.
Let's see if we get that question. Oh no, so we went too fast.
Okay, 42-year-old non-smoker.
I think you lost it. Sorry. Here we are. Yeah, here we are. Okay.
Okay. A 42-year-old non-smoking man presents to the office with exertional calf pain that begins after moderate exercise. The pain has been progressive over several years and is now limiting activities of daily living. The right pedal pulses are weakly palpable with the ankle brachial index of 0.6. A duplex was performed showing 1.7 centimeter popliteal artery with possible thrombose dissection and luminal narrowing. A CT angiogram was performed and showed a focal cystic structure within the wall of the mid-popliteal artery measuring 1.6 centimeter in diameter. The next step in management is, so he's talking about an aneurysm?
No. Just a second. This is a tough question for you, Ahmed. This is very rare situations, you know. You see, this is cystic structure, then say aneurysm, you see? So this is called cystic adventitia disease. It's very, very rare, you know. I mean, I don't know if I saw a case in my life. Maybe I saw once and asymptomatics, you know. So, I mean, it's not fair to put this question here. But this is a cystic, you know, adventitia disease. Usually you see it in popliteal artery in the wall. It's like a cyst in the wall and cause compressions, you know. Reason why patient has all the symptoms, you know. How you treat it? Usually you can drain. It's a cyst. You can just aspirate it because they don't know people they think it's a cause of trauma. Some people they think it's congenital. Nobody knows really what the main issue. But again, I never had to treat any of them, but I know that if you get it, you usually first try with the aspiration. If it doesn't work, then you have to do either replace it or stent it, or you have to treat like any disease. But first, try to drain because the compression is outside compression. It's a cyst in the wall of the popliteal artery. I mean, I'm saying it's very, very rare. Ali, did you see any case like that?
We see some, and
Wow.
I do a transection of the whole segment because someone says that you have to open the cyst and to liberate the artery, and it's enough to do like that. But I don't know if it is enough to do that. I think it's better to take off all the segment of the artery interested
And what the
and to
position
put
in vein graft.
bypass. Yeah, it's better. It's better.
Yeah,
Because
the problem is that
the recurrence may be in these cases. So personally, I transect the artery and I put a prostate a bypass.
Yeah, I agree with that. The problem, as I said, Ali, it's not very common, so you don't have really very strong recommendations. But what I usually, as I'm saying, I never had to deal with it, but I read about it one time that what you do is just spray it. If it doesn't work, then you have to resect it, yes. But you can try first, maybe it works, because it's very simple. Just put a needle and aspirate and see. But if it doesn't work, then yes, I think you have to resect it, you know. What's the next step?
No, I don't know. It's if you have to put a needle and aspirate, or better to open the cyst and resect all the cyst.
If I have to and open, then no, I go with you. Is the reason why I said the needle, because you don't have to open. But if I decide to open, then I just take the whole artery and put the vein graft. I think it's better. You see, if you have to open, then it's better just to take it out. Because if you just drain it and then come back, it's difficult to go back again through it, you know. So if you commit yourself to open, I think it's better just to go and resect this part and put the vein graft. Well, let's see what the options give us. Okay, let's go with that. But go, Ahmed.
Okay, assurance that this lesion is self-limited and will improve without intervention. I don't know.
But patient is symptomatic, right?
Yes.
Let's see what her symptom again. She has
claudication.
Yeah, severe exercise. So she has symptoms. So we have to treat her. I mean, if you find it incidentally, I think yes, you can leave it. But I mean, if you have symptoms, then you have to treat it. Okay.
Angiogram with balloon angioplasty and stenting of the lesion. The lesion is outside the wall.
Yeah, and it's compression, it works, but popliteal artery, you don't want to put a stent in the popliteal artery, as especially young. How old is she? She's young, right? She's 42. So it's not the best option, you know? So I don't think it's the best option. Yeah, okay.
Percutaneous drainage of the cystic structure.
You can consider that, we talk about it. Next one, let's see.
Or popliteal artery dissection with arterial resection and interposition grafting.
Okay, so Ali, he talked about it. Next, last one.
Bypass of the popliteal artery using saphenous vein.
Yeah, and it really is, all of them is correct, you know. It depends what the situation. Like if patient is old patients, you know, like again, like 80 years old, and you find it, you can do ballooning and stenting, but not young people. Popliteal resection also, again, as I said, resection is an excellent idea. You take it and put a position vein graft, especially as young, and you finish with the problem. Also, is a good options. Bypass of popliteal artery using saphenous vein, yeah, and it's not also bad options. But I think the next step is always maybe just want to drain first and see. But it doesn't work all the time, as Ali said. It doesn't work every time. But I can assure you, I don't know, Ali, how many you saw? Because I really never saw one of them. I mean, you saw it in Syria or in your training in Italy?
Every 1 year or 2 years. And we think it can be complicated or can be taken for entrapment popliteal artery syndrome. So in these cases, we take in consideration the presence of the advential cyst, popliteal cyst. So I think about 4 or 5 cases that we saw.
That's good.
Not more.
Maybe you should try draining, see maybe it works. Maybe try it and tell us what you think. Because, you know, try draining one time and see if in future.
If you drain a cyst, I know that the epithelial membrane will re-give or
I see.
The liquid another time. So you don't take off the epithelial cells or the epithelial membrane. So you will have a recurrence if you drain it. I think so.
Okay. What about if you find patients asymptomatics?
Even.
Leave it alone, right?
Even. Yeah, you have to. No, I treat them.
Oh, really? If patient is asymptomatic, you treat them?
Before they become symptomatic, yeah. Before they become symptomatic.
Well, as I'm saying, the problem is that we don't have very strong data because it's not very common, you know. So So I don't think, I think you have to take case by case and decide what's the best treatment for the patient.
You
All
have
right.
to take case by case.
Yeah, I think so. Yeah, depending where it is, the location, everything. Okay. Yeah, they did the drainage. Okay, let's say 42. We go to Muhammad. We have time.
I will.
Yeah. Oh, it's already time is finished. It's 9 o'clock. Okay, guys. I think we can stop here, and we'll meet next week. Hopefully, next week we'll finish the lower extremities. I mean, we have to finish it. This is the last, Then we can move to next category. So hopefully next week will be the last session for lower extremities.
Okay, doctor. Thank you.
All right. Okay.
Inshallah.
Thank you, guys. Thank you very much.
Shukran.
Goodbye, Ali.
Thank you, Dr. Samer.
You're
Hi,
welcome.
hi to everyone.
Thank you.
Thank you, Doctor.
All right. Let's do.
Assalamu alaikum.